Good.
Madam, we are live now and we are starting the program. So good evening, doctors and all the participants. On behalf of Shield Healthcare, I welcome all the dignitaries in today's session on menstrual health in girls in resource-stressed settings. Let's talk about stuff, space and solutions, and it's presented by Karnataka College of Obstetrician and Gynecologist along with Artists for Her and in association with Shield Connect. So now it's time to introduce Dr. Hema, ma'am. It's our privilege to introduce ma'am. Chitra. Yes, although madam doesn't need any kind of introduction, all we know, but it's my formal responsibility to introduce ma'am. Ma'am is the CEO and chairman artist, chair of Women Healthcare Committee at FIGO. Ma'am is the Dean KCOG, President DIPSI, Vice President HPI, and Madam was the first President of FOXI 2013, first Vice Chair for FIGO PNCD Committee, and advocate for delivering quality healthcare convener Manyata, an opinion leader and an influencer for social and legal issues relating to women's health. And in terms of awards and recognition, FIGO Women Achievers Award ma'am received in the year 2015, Global Asian of the year 2018, CME Excellence Award for Artists, Next Brands Award for Artists for Her, CSR Times Award, and CSR Impact Award for Adivaka Service Trust. So with this short introduction, I request Madam to take over the session for further proceedings. Thank you.
Thank you so much to Shield Connect team, Suman Saha, Chitara, and the Balaji and the entire team. Can we just have the prayer, please?
Chitra, please lighting the lamps.
Yeah. Namaste, with greetings to our very distinguished speaker, May, on the backdrop of Deepavali, which is a festival of lights, taking us from darkness to light, ignorance to knowledge. And thanks to our patron, Dr. N.G. Hiremat, who has given us ample opportunities to repeatedly deliberate with the global audience, bringing in very distinguished speakers to deliberate on what is happening across the globe. Dr. Bharti Rajshekar, the Secretary General of Kasoga, and Dr. Basavraj Sajjan, immediate past president, and Devakar and Shilpa Joshi from Team Artists. Before I unfold the impressive bio sketch of our speaker, Maeve, I would like Dr. Hiremat and Dr. Bharti Rajshekar to make a few opening remarks, because we are meeting at KCOG after the state annual conference of Kasoga that we have had in the beautiful premises at Hooghly just about 4 weeks ago. And we are still in the aura of the brilliant execution of the event. Hiremat, please.
Thank you, Hema. Respected Dean, guest speaker of today, Mian Guven, backbone of this program, Devakar sir, Dr. Basavraj Sajjan, all the office bearers of KCOG. This is almost more than a year that this program is going on. And in fact, I feel it is a great opportunity for all of us to listen to the experts all over the globe. Every month, Dr. Hema is taking immense trouble of getting the best of the speakers. And every time we feel that this speaker is better than the last. And it is going on, and a variety of subjects, and they are all experts. They have such a wonderful statistics I think it's more than knowing everything what is happening in the globe. And today also Hema has arranged such a wonderful talk. I do not want to take much time. I just want to wish this program a great success. And I wish that lot of our Kasogians and also KCOGians will be benefited. Thank you, Hema.
Thank you, Hiramat. Bharti?
A very good evening, and on behalf of the Karnataka State OG Association, I welcome Professor Mayab to this very important webinar. And as Dr. M.G. Hiramat rightly said, HEMA takes us around the world every month. And it is indeed a privilege and an honor to have such eminent speakers speaking to us and all our participants on such topics which are the need of the hour. The heading of the topic today, let's talk about stuff, space, and solutions, is so well framed, the phrase, and very often as practitioners, we do not spend time to speak about this basic need of women today. I think it's time that we all take 2 minutes and speak to our women, especially those in the resource-stretched settings, talk to them about menstrual health, menstrual hygiene, and sustainable menstrual devices to give them a good menstrual hygiene. So without wasting much time, as Dr. Hiramat, we have a lot to hear and looking forward to listen to you, Dr. Mayab. I wish this webinar a success, and thank you, Hema, for giving me the opportunity to say a few words.
Thank you very much, Bharti. We acknowledge the presence not only of Basavaraj Sajjan, the immediate past president, but also Dr. Vidya Bhatt, who is the dynamic secretary of the KCOG, whose passion is for skill transfer, and she's been harnessing the skills of many youngsters, not only in our state, but across the whole country, I must say. Now it's my proud privilege to introduce our distinguished speaker, a very beloved friend, and an asset to our committee at FIGO called the Well Women Healthcare Committee. She's an integral part of that. And when I take you through her bio sketch, you will know a variety of things. My team had put everything just in one slide, but I said, no, this is worthy of sharing with my friends and colleagues who are watching this. About hundreds of them are hooked on to the webinar today, and they must know that Dr. Maeve is a consultant obstetrician, clinician, manager, and educator for the last 2 decades at the Mayo University Hospital in Ireland. She's the ex-dean of medical education at the Mayo Medical Academy. As I said, she represents Ireland at the FIGO on the Well Women Health and Care Committee. She's currently joined the humanitarian agency, MSF, and this work takes her across the low resource stretch settings as well, and she has much to share from that experience. She is a fellow of the Royal College of Physicians in Ireland, and also the Royal College of OB-GYNs of England. The advocacy and policy initiatives is worked on the national maternity strategy and implementation teams. We have all recognized that innovative ideas come forth by the minute, but to strategize and implement it to have an impact, that's the strength of our distinguished speaker today. She worked with the WHO advisors in Ireland on the introduction of an ethical framework training tool on reproductive health, choice, and rights. She has held Irish Aid Civil Society fund grants for the global twinning accredited hospitals. And as we go along establishing more connects and contacts with Professor Maeve, we would like to explore more on the quality and accreditation processes for our organizations as well. How did this all begin? She's a qualified medical doctor at the University of Dublin, Ireland, and she completed the dual specialty certification, not only in OB-GYN, but also in general practice with additional overseas training in Australia and Kenya. She's completed the MSc in Public Health and Diploma in Tropical Medicine from the London School of Tropical Medicine and Hygiene at the Institute of ONG RCPI. May has held multiple roles in serving on the executive board, the clinical guideline group, and various technical groups. She was also the National Specialty Director for the Basic Specialty Training Program and also the Irish Forum Postgraduate Medical Training, which is a passion area of many of the office bearers of the Karnataka College of ONG as well. And the new collaborative postgraduate training program with East Central and Southern African College of Obstetricians and Gynecologists. Professor Maeve, this is yet another area where we want to explore the collaborations. And she has also led, most importantly, put the patient in the center of all the work that you do. So patient-led engagement, quality initiatives, and serving as the chair of the General Hospital on the medical board. So if I have to speak more about Maeve, that will be yet another whole lecture. I'm so very proud and privileged to introduce Maeve to our audience here. And Maeve, if you want to make some opening remarks before we play out your deliberations on the topic today, on the stuff, space, and most importantly, the solutions which we can offer. Maeve, all yours now.
Thank you very much, Hema, Dean, Chief Patron and immediate past President, distinguished audience. I am very privileged to be here with you today. I am a general obstetrician gynecologist in a rural area. I am just reflecting on my life experiences as I do not purport to be an expert. But I am so excited to hear of your development in postgraduate training and transferring skills to the front line because our resource stretch settings are everywhere and we can find the solutions by working together. So I think that's all I have to say for now. I'm sorry about my long introduction, Hema. You're very kind. Thank you. And it's probably just a sign of my age, I guess, that the introduction is longer.
No, I think the more knowledgeable, the more humble the person is, and it reflects well in the humble introductions that you made for yourself in your opening remarks. May I request the technical team to roll out the deliberations on the topic today, please? Thank you.
In Mayo, the western seaboard of Ireland on the Atlantic Ocean, where the Ukrainian flag is fluttering away as we host quite a number of refugees in our community. It's quite a way from India, over 8,000 kilometers, and I have not yet visited, but in due course I hope that I will be able to visit. I have no potential conflicts of interest to disclose. I present purely as a peer facilitator. I will use the term girl in this presentation to include any young person aged 10 to 19 years who identifies as female or a person who menstruates. It is through FIGO that I became aware of the Well Woman Healthcare strategy, driven by some of the American college work, but driven in every country by flipping the way we consider health and healthcare. As we know, health is not just the absence of disease. It requires a lot for girls and women to consider themselves healthy. And in the FIGO setting, it's the first time there's been a specific committee to work on well woman healthcare. And my stream of work within this group is to consider adolescent healthcare and menstrual healthcare. Of course, FIGA has the vision that women will attain the highest possible standards of health, particularly reproductive, sexual, and health and well-being throughout their lives. And to do that, care needs to be safe and respectful. It needs to consider the climate and planetary and environmental constraints. It needs to consider in particular women in crisis settings and fragile settings, and all grounded in the ethics of sexual, reproductive, and children's health and rights. For this session this evening, I would like to suggest these learning objectives, but you might like to suggest your own. And if I don't address your learning objectives, perhaps you can add them to the question and answers after the short didactic component. In my interpretation of the title of this discussion, menstrual health in girls in resource-stretched settings is moving our thinking as a group of obstetricians, gynecologists, away from menstrual hygiene and more into holistic care at whatever touch point we have with the girl or the young woman who may have some menstrual health challenges. So in setting out that content, I wish to consider how we would revise the one-to-one well woman, well girl adolescent consultation using menstrual health as a purposive entry point into a fuller adolescent health consultation. I would like to reflect on the provision of adolescent gynecology services in the wider intersectoral context of preventive sexual and reproductive health and rights. And I would like to reflect and understand the population-based actions that pertain to menstrual health in its broadest reach. Paul Farmer, who sadly died this year, one of the leaders in Partners for Health, stated that global healthcare is understood to mean the provision of a limited set of health services to underserved populations in resource-poor areas of the world. But in reality, global healthcare is the clever distribution and provision of healthcare services wherever we are, as all of us have elements of our setting that is resource constrained. To start with our own context as global gynecologists, most of us practice in my setting, most of us practice obstetrics as well. So the driving force in obstetrics is to really try to reduce down preventable maternal mortality. And we see that happening worldwide. To reduce down sexual and gender-based violence and harmful practices such as early marriage and teen pregnancy and genital cutting or mutilation. But we are not seeing the results in this target. And to reduce down the unmet need for family planning. And again, this is a challenge to drive throughout the world. We also have to work in a global surgical system where we have resource constraints in surgery, anesthesia, obstetrics, perioperative nursing, and midwifery. We share the same challenges with infrastructure wherever we work, with supply chains and with leadership and good governance. All of us are on the same continuum in ever trying to improve. And all of us are stretched from time to time with the comprehensive emergency obstetric care services, as it is such a firefighting service, it's such a present service, that it's hard to keep the silent gynecological needs at the table on the agenda. And despite that, gynecological disease has overtaken maternal health in the global burden disease estimates, including obviously cancer, particularly cervical cancer, menstrual health, menopausal issues, and fertility, urogynecological problems, and fistula, contributing to productivity reduction amongst girls and women. The global burden of diseases in females aged 15 to 49 is presented here. And you can see gynae in the first row, taking a major tranche now in the sectors away from infectious diseases, away from iron and neonatal care. And maternal health care is reduced down quite a bit in the global burden of disease. Obviously, it's still a major challenge for us, but the context is that we need to be readying our gynecological response, getting ready to move it faster and more efficiently and more responsively to where it is needed most. As a specialist gynecologist, we do bring added value to menstrual health. So not all elements of menstrual health can be shifted to the community, to community health workers, to community providers. We retain a need to engage in comprehensive and complex gynae care, leadership and training, to be surgical providers and teachers, and to lead the sexual and reproductive health services, particularly with values-based ethical frameworks and rights modelling. And Ireland has gone through transformative change in the last decade over public referenda on the right to choose in relation to safe abortion. We remain the key clinical informants to high-level leadership at government and regulation level. And we also are the ones who can measure. For data-enabled delivery of services, we can identify what are the key indicators that can inform policy. But we must think widely about our subject in order to influence policy well. We also need to future-proof ourselves and think about our fit. As reflective clinicians, how do we provide appropriate adolescent services, and how do we fit in the intersectoral context? You might like to brainstorm on resource stretching, but I suspect all of you knows when you're stretched and when you are not. Over-specialized care, lack of universal health care, non-ring-fenced funding, rural geographical distribution of users and urban distribution of providers, conflict and humanitarian settings, displaced populations and their hosts, and vulnerable groups. These are the settings I mean when I say resource stretched, and of course they are in every country and in every subnational unit, but obviously on a different economic scale according to the economic background. When I asked our third medical students, average age is about 20 years, recently about what sexual and reproductive health means to them, they came through with this word salad on quite a positive approach to sexual and reproductive health. They're comfortable in talking about family planning, autonomy, choice, sex, and hygiene. However, when I asked them the same question about menstrual health, their language, their nuance, their hesitancy in contributing to this poll was clear. They had not framed a concept around menstrual health at this point, even though they were more than halfway through a global health and development course. The language you can see here is about stigma, about being tough and messy and poverty, and about it being complex and lacking. So clearly, menstrual health is not yet in the vernacular of these well-educated students in the west of Ireland, majority of whom are Indigenous to Ireland, but about 20% are international students. So if we move on to our menstrual health consultation, as we will start in the clinical realm as clinicians, when the adolescent presents to us seeking clinical care about menstrual health, it may be that she's completely normal, seeking reassurance. It may be that she or he is having bleeding that they consider not normal and is seeking to ask why. It may be that menstruation has not started when they think it would, or it may be that it causes pain and school absence. So as clinicians, we can very easily get into the consultation style of managing the presenting clinical problem, engaging with the family member or guardian who may or may not be with the adolescent, trying to establish rapport so that we hope to see them again and they will be more comfortable in their consultation, and perhaps offering a little bit of education. Perhaps we think about their nutrition and eating habits. Perhaps we think about their school and family and work influences. We might investigate if there's something to point us towards anemia or coagulation problems, or if cycle length might be a sign of underlying endocrine conditions. But is this good enough as a mental health consultation with a gynecologist? That is quite a rare resource. Have we gone far enough? Did we think about doing the blood pressure, measuring the weight, plotting the growth of the child on an age and gender appropriate graph? Did we open the agenda regarding harmful practices and exploring sexuality, preconceptual care, contraceptive care, mental health position, substance use, injury avoidance, and so on? If we remember back to 10 or 12 years ago, Professor Nicolaides challenged us to think again about antenatal care, that we waited the late pregnancy for care, where we now know that early pregnancy is when the risks can be assessed and then care can be targeted appropriately. So it flipped our thinking about how antenatal care should be delivered. I would propose for the purposes of this session this evening, that we might also think about turning adolescent gynecological care upside down by burden of disease analysis and core competence analysis. And instead of weighting clinical care and other clinical conditions as the major part of our consultation, that we keep the clinical side quite small while we establish rapport, while we think about what education needs this particular adolescent may wish to engage with. And we think about prevention and handing over the responsibility of self-care to the child. But as you can see with the arrow on the right, the clinical commitment with this flipped consultation is great. And in our settings, we often are under pressures of time and double duties, and giving that safe and undisturbed consultation can be quite difficult. To work in this field more effectively, we do have to step out of our situational clinical care and go back down into the foundations of adolescent care outlined here by UNICEF. So we have to understand adolescent development and the implications that brings to the clinical practice. We have to have age and stage appropriate communication methods. And we have to think about how that particular adolescent, that particular time, and this particular consultation wishes to engage. We also have to be cognizant of our laws and policies and quality standards, whether we're chaperoned or not, whether we give the adolescent some one-to-one time with permission of their parent or guardian, recognizing that they may have complete autonomy. The younger adolescent may choose to keep somebody with her, and the older adolescent may or may not. And when we get into our clinical care for specific conditions, we would know the clinical management quite well. We can deal with bleeding with simple non-steroidals and simple pain measures, recommending exercise, recommending continuing school and work. But if the context where the girl or young adult is does not afford them the privacy for menstrual hygiene, it is very difficult to address that. There's a link to a video here for any of you watching asynchronously and set in the Jamaica adolescence frame. But think about the to-do list for an adolescent. Gosh, they are so busy. They have to separate from their parents. They have to find their place amongst their peers. They have to make decisions about their future. They have to figure out how to relate to the world in general. And then they have to figure out how to relate to themselves as a suddenly and mystifying sexual being. And we have to be comfortable as gynecologists in allowing that sexuality discussion, in recognizing that this person in front of us, who may look like a child, who might behave like a child, is an adolescent and is a sexual being. And by bringing our rights-based approach to this particular health consultation, we can remind ourselves that this child has the right to good information, to preventive care, so that she or they can achieve the best health available to them. And we know that returns are really good. If there's good adolescent health care, it can really influence what happens for health outcomes now in that phase of life, in future life course, and in the next generation. So the triple dividend is very strong. To frame our consultation content, we need to think about what are the real causes of ill health in the age group. And on the FIGO Well Woman webinar last week, which you can find on the FIGO website, you'll see some of these burdens of disease discussed in more detail. It's important to know what's happening for both males and females and to understand why there are disparities besides the physical disparities that occur. And you can see in these graphs that are stratified according to income settings, there are differences. You can see on the left side, the boys, the young males have more injuries, whether it's road injuries or interpersonal violence or self-harm, than the girls. But we have to be cognizant that some of the girls are becoming equally as risky in their behaviours, in gang behaviours and in violence and in road traffic activity. And if we focus in more detail on the girls, we can see that the communicable diseases still cause quite a high burden in both the 10 to 14-year-olds and the 15 to 19-year-olds. But the difference in the older adolescent is the maternal conditions become much more prevalent globally and inversely within a lower income setting. And note the anxiety and depressive conditions that are represented in the higher income setting. So knowing the analysis of burden of disease brings us into thinking a little bit more as population health scientists, whether that is our style of practice or not, to understand population health and to think about how we can be impactful. We need to understand where we fit and where our effort will be rewarded. And this particular framework from the American Public Health Association shows, of course, what we know, that socioeconomic factors determine health, with education and marketing programs to make social change occur. We're going to have a more sensitized population. I'm following up on the right-hand side now, coming up through the sexually transmitted infections. A sensitized population or a triggered community will have a greater human papilloma vaccine uptake. There may be more awareness and frankness about discussing sexual transmitted infections as the vaccine's already been established, and screening for infectious conditions using barriers and using oral contraceptive may be more easy in this sensitized community. However, the individual commitment to engage is great for the provider in this consultation style. And on the left-hand side, as we rotate around, if we engage in the adolescent and use every touch point as a preconceptual visit, avoiding smoking, alcohol, promoting breastfeeding and folic acid can improve the newborn outcomes, having her fully vaccinated as she enters adolescence, and considering her context from a poverty reduction and economic empowerment will improve the newborn outcome. So this is just an example of how approaching an adolescent consultation very much as a public health exercise for impact might change our approach to engaging with these teams. This table shows the USA Women Preventive Service Initiative updated this year, 2022, on the types of activities that should be included in the adolescent visit. So the setting in the US is very diverse, as you know, and some girls and women have access to a high level of services, and some have very limited access to free reproductive choice environments. And of course, it's election time there, midterm elections at the moment, and sexual and reproductive health rights are a major issue in that particular, in all societies, but particularly in the US at the moment. As you can read, hopefully you can see the small print there on the screen, screening for substance abuse, screening for non-communicable disease, screening for conditions that are common in your population, so cardiovascular disease in the American setting. And of course, it's becoming a wider burden of disease globally. Screening for tobacco use should nearly all be starting as young as the Americans say 13, but I'd like to propose that we would consider it at 10. What if this 11-year-old in front of us is the 1 in 100 of all 11-year-olds who's going to bear a child before she's 14? Or what if the 15-year-old is the 3 in 100 who's going to bear a child before she is 19? We have lost the opportunity for preconceptual engagement and contraceptive counselling if we don't cast our net wide enough to capture them into this consultation. And every time we think about prescribing the pill, do we think about pre-exposure prophylaxis to HIV? At a recent Zimbabwe meeting, and we heard very interesting work coming from that community about combining PrEP with OCP. And India leads the way in so many of the rollout of globally affordable medications, even though its burden of HIV is not the same as sub-Saharan Africa. And what about cancer prevention? So you can see in this particular table, very little comment on cancer prevention for the young adolescent. And again, I'd like to say that perhaps we should be doing specific targeted interventions in this age group, because the child arriving into adolescence with obesity, with poor nutrition from the over calorific nutrition, is at much higher risk of breast cancer and colorectal cancer. The child eating processed meat or a lot of red meat, because that's the local culture, is at higher risk of colon cancer. The child exposed to air pollution and tobacco smoke has a higher risk of lung cancer. And if we don't think of the life course of this person in front of us, we've lost that opportunity to engage and intervene at a time where it may well make quite a difference. But behavioral change is a harder intervention to achieve. So if you agree with this concept that the adolescent gynecology consultation is much wider than what is suggested by saying it's a menstrual health consultation, then the standard model shrinks down to the small pyramid on the left, and the new model becomes a much larger pyramid, a bigger consultation, a lot more effort, but an effort for which we should see a return if we can reach a sizable proportion of our population. In building rapport, we can destigmatize the issues, create a safe space, think about rights, think about non-directive psychological support, and allow sexuality dialogue. We can spend some time on good, appropriate education, as opposed to the child or adolescent depending on typically her mother for information. And her mother obviously is generationally different and may not have received objective information. We can think about screening, we can think about preconceptual interventions, we can think about preventing HIV. And the triple threat for adolescent females globally at the moment is gender-based violence, teen pregnancy, and HIV. So despite our Nairobi goals to reduce harmful practices and to meet the need for contraception, unfortunately with the pandemic, the world is sliding back in these indicators. So at this point, we've considered the consultation and we've widened it into a more holistic consultation. The next step is to consider how we act in our sector and how we bring our knowledge and ideas into the community action for the communities in which we live. And we obviously need to be aware of the sectors that you're all aware of and make sure that menstrual health fits in health, because and that it integrates with sexual reproductive health. It's rare in the strategies published today from Lancet, Guttmacher Commission, through to specific menstrual coalition strategies from Southern Africa, from Southern Asia. It's rare for them to mix menstrual health and menstrual hygiene with sexual and reproductive health. And of course, we know that the two are completely intertwined, and every biological touch point is an opportunity for engaging the entire agenda. We need to give some consideration to social protection issues with humanitarian works with development partners and with public services for youth. We shouldn't shy away from academia and the private sector, even though as clinicians we get busier and busier, and it's sometimes hard to find that time to put those thoughts together in a paper. And we should remember how we fit in a structure, a system, because without that system-wide critical thinking, our endeavours will be less effective. We need symbiosis of working in the system. A community health strategy with integrated sexual reproductive health and rights, it can bring menstrual health to a much higher reach, much more quickly. And understanding community health is something that I believe your society is very strong in, and it's something that my society is still relearning over these years as we go out with the new maternity strategy, and with that try to regain some confidence in our cervical cancer strategy. We're all making good progress in the gender gap composite progress. As you can see here, there's not huge differences across the regions. However, we're still lagging in social and economic empowerment, and menstrual hygiene, sexual reproductive health, and the impact that causes on school performance and work performance is one of the small contributors in the wider gender agenda. So we have the solutions. We know we need to break down stigma and embarrassment. We know that we need to engage with public health and education. It's not enough to be a clinician. We need to advocate for reliable, publicly available information and toolkits for providers and adolescents. We need to, at higher level, recommend the joining up of the commissioning of services with better access. We need to think with financial hats on about ring fencing of public funding and reducing out-of-pocket costs. We saw huge benefits here in the maternal and newborn health sector. We need to consider fragile settings with extra attention, making sure we follow with needs assessments, using good health information systems, checking alternate supply chains, leveraging the actors, and working across the centres. And we shouldn't be afraid of redeployment and the disruption that that entails. And the big challenge then for those of you working in the ministries is how to replicate and how to do it at scale. And so to finish, menstrual, sexual, and reproductive health is a function of civil society, not a disease. It's a measure of the human right of the girl to life and freedom of choice, to freedom from unsafe practices, and access to quality healthcare. It's really a social and political choice rather than a personal choice. And so to conclude in relation to our learning objectives before we go into the moderated part of the session, the adolescent gynae consultation opens the wider agenda of sexual reproductive health and well-being. We can use it purposefully to signpost to youth services and to support the child's right to health, his or her or their right to survive, grow, and develop. We do need to consider becoming actors, if not already, in rights-based adolescent gynecological services at scale. And we do need to look at the geographic distribution and how we are contributing to that as individuals and as learning communities. And by using the resource poor, the constrained conceptual frame, we think a little bit more cleverly and effectively about health service delivery. Using FIGO's umbrella, and in time when this committee reports on its work, we can take the overarching principles of safe, respectful care, a planetary approach, a focus on girls and women in crisis or those with vulnerabilities, and we provide care in a values and ethical based environment. Mike Ryan, who's led the WHO's emergency as an epidemiologist, used to be a trauma surgeon. He's from a place in the west of Ireland, not far from where I'm sitting now. His quote that resonated with me: "Be fast, have no regrets. If you need to be right before you move, you will never win." Thank you very much for your time and attention, and I will hand over to Dr. Hema Divakar, Dean of College and moderator for the live question and answer session.
Thank you so much, May, for expanding our thought process from menstruation to a lot many more things for adolescent care. Thank you so much. We have a couple of questions from audience, but before I take that, I would want Dr. Hiremat, Dr. Bharti, Vidya, and others to voice out their reflections on what they've heard, the kind of work we've been doing, or what better we can do, and more advice and solutions what we can have from the experts. Hiremat?
Yeah, thank you, Mabet, for such a wonderful talk, and so nicely covering all the adolescent health problems, and especially in our country, I feel we have not yet developed to that great extent, but the way you have given a global picture, it is an eye-opener for all of us. I think you are working at a very ground level. That's why you are able to take so many important things. Thank you very much for opening our eyes in this field. Probably I feel in the future, there will be a subspecialty in gynec called as adolescent gynecology, that we have to practice only this to give justice to these adolescent girls, which have so many problems, which you have told, especially regarding their contraception, preconception views, their gynec problems. I think it's a need of the hour that we must open our eyes for all the gynecological problems in adolescents. Thank you very much for a wonderful talk.
Thank you. Thank you, Hiremat. Bharti?
Dr. Webb, you have wonderfully put it across that the future is in our adolescence, and the triple dividend that you did mention, that is what we do now is going to pay us the dividend in future. I think, as Dr. Hiremat said, we need to focus on adolescent health. And I think every basic gynecological clinic should have a focused adolescent health clinic where we can counsel them, spend time with them, address their physical as well as their mental issues, and try to help them have a healthy future, which leads to a healthy globe, and hence reducing the incidence of not only the communicable diseases and anemia, but also the other issues like the mental health issues and the drug abuse, and all these are interconnected. So I think it's time that though we are speaking about maternal health, I think adolescent health is still in the back seat, and we need to bring it to the forefront. And I think this is where each one of us needs to have a focused approach, and the strategies that you have given us, the stuff, the system, the services, the staff, and the support. I think we have to get all these together to provide a very supportive system to these adolescents globally. Thank you very much for being with us with Kasoga and KCOG. And thank you, Hema, for bringing up this wonderful topic, which is, I think, the need of the hour. And we all need to take this up intensively, I would say. Thank you very much.
Thank you very much, Bharti. Before I go on to taking some comments from the other important members whom I can see on the screen here, there are a couple of questions from the audience about a few hundreds who are watching this program. They agree with the inverted view, the reversal of care, the reverse triangle, which you compared with the antenatal care and the changing thought processes, the same aligned with the care of the adolescents. But the question is, how do you get at these target adolescent group? Even if you have youth-friendly services, adolescent gynecology clinics, they will not be very willingly forthcoming to that, especially because of the stigma factor that you mentioned. So how do we work our way around it is a question.
Thank you, Dr. Divakar. So, of course, it's a difficult question. So, because our limbic system is developed and our prefrontal cortex is developed by virtue of age, we're not attractive to this age group. So one of the key workings is to use the peer educator system. And I think in your setting, as well as in some of our settings, we found it worked really well with young community mothers in teenage pregnancy. It worked really well in HIV, in encouraging teens to come for voluntary testing. And we certainly know that it also helps in alternative rights for those communities where there's still harmful practices. So where schools are established, and that's why I was keen to show the global gender gap improving. If the girl stays at school, or if the menstruator stays at school, then having clubs within the school with training the trainers as peers is one reach. But of course, it's where are the vulnerable girls and menstruators, the ones who are not staying at school, and using the youth development sector and the community-led actions. The communities know their own solutions. If their basic needs are met, if they have food security and clean water, then they often are, as you know, they're sensitized to learn life skills. And they are usually quite prepared to do that as groups of people, and include the youth. The communities that I've worked with over the years have been very strong in making sure that youth is represented. But you're quite right, as obstetricians, gynecologists, they don't land on our doorstep. So that's why we have to think about outreach. And we might not be the main provider of the outreach, but we can be the facilitators. We have the training skills. We have the leverage at high level to get funding. And so our role is to understand the process and then to use what our particular communities have shown to be successful before.
Right. Thank you, Maeve. Another question that is coming up on my group is education was a large part. And then somebody has been very attentive and seen that blue icon of some video from Jamaica, which we did not actually see. So they're asking whether do you already have some resource material that could be shared with the common messages and we can build over it in our context. So is there anything that exists within?
Yes, so I can actually send on some references to the Menstrual Coalition toolkits, and certainly the Guttmacher Institute and UNICEF have good toolkits. But the videos, as we know, is the way of the future, particularly for this age group. So that social change, which is now a key element of our systems thinking, is going to be with the young user posting, that young influencer. And we just don't have the right profile to become that influencer. So we have to find the young persons to do that. Of course, we do find a lot of these younger women in our maternity services. So while we might not see them in the gynae services, we can certainly create more adolescent-friendly gatherings within our maternity services where possible. And if they're all disappearing home very quickly, where we have succeeded in improving facility birth, it's how to capture them with the community extension health worker, capturing them following discharge and using that touch point as a full adolescent engagement point.
One last interesting questions on my list here is there anything that we can do in a mother-daughter combination? Because so many mothers and, the age group will come to us. So keep tapping them about how many daughters they have. Can they bring them for preventive healthcare checkup? And has this kind of a mother-daughter initiative been worked out in any part where you've been a part of it? And can you share some solutions with us as well?
Yes, thank you. So the mother-daughter relationship is very useful in many ways, but the phase that the adolescent is at is the breakaway from the mother. So the menstrual health and hygiene interventions were set at a younger age, typically maybe 9 to 12. So they're there at the beginning of menstruation. And we're still a little bit afraid to do the full sexual health agenda because it is more challenging to be sure about consent, to be sure about capacity of the child, to enter into that space without the mother's engagement. But she can also hold the child back. So certainly in my East African experience and in my Australian experience, outreach into the schools where there was parental consent, but the child was allowed to attend with the parent if they wanted to, or more often as a group. Yeah. Now, but if we do flip the model and spend more time on prevention and interventions, engaging the mother, as Dr. Hiramath said, adolescent gynecology is really a specialty of the future. It's just tagged on to the end of pediatric gynecology at the moment, but it is where the future is. We just have one in Ireland, in our country, our little country of 5 million. I'm sure in your huge country you have many more. But it's dealing with the two patients. The mother is often reliving her poor reproductive experience, her poor menstrual health experience, and some of the illness behavior then is created around menstrual health behaviors. And we know in many of that dyad setting that separating them out and getting the peer group can be more effective, but it has to be with consent. Maybe some of the other distinguished members of the college here have ideas on how to work with the mother who may or may not be dominating the space with the child.
Right. Thank you so much. I think I can see Dr. Shobha Gudi, Shobha Bembalgi, Dr. Vidya Bhatt, Lalitamma, and of course Dr. Sachin. Anybody wants to, in the last 5 minutes that we have before Manjula Pandey proposes any more queries, questions out of thanks, etc. So anything that you want to raise with us, this is our chance. Shobha?
Hema, thank you very much. You brought in wonderful discussion on adolescent health, and I really thank the speaker for having brought in so many perspectives. I just wanted to share that, in the process of educating our adolescents for sexual reproductive health, which we have been doing over the past few years with Foxy, we came across a lot of research in adolescent approach that healthcare providers can do, and what is becoming increasingly evident that adolescents respond better to non-parental adults and peer interactions rather than the teaching faculty or the parents groups. So that is what I just wanted to put across, that we need to open up our minds to the fact that adolescents may not be very approachable by healthcare providers, and we need to create a via media a group of counselors who are amongst them. And I remember Hema distinctly saying once that youth care and adolescent care, the feeling is always, if it is about us, it has to include us. So peer educators from amongst their group, I think we need to focus on that. Thank you so much for the time, Hema.
Thank you. At this point, since the distinguished speaker is here and all our leaders are here, I just want to park one important thought process which is emerging as probably, something that we can experiment with. And that's the last slide of me I would refer to, that, you need not always be right to start something. You just have to start and see how it evolves. So we are conceptualizing wellness villages where it's the healthcare, preventive healthcare and wellness for the youth, but it is also including the entrepreneurship and livelihood, because we pick up the young girls from the community itself, and we do a small model of digital training program for them, and they are the key link people to go around the entire village to make sure that the messages are conveyed in the manner that it should. And we are just experimenting with this model, and we do tell them that in a confidential and an anonymous way, they can get back in touch with us for a video consultation. And that is, the digital India is a huge leap forward. So I think we will have more lessons to learn and experiences to share as we go along. So one last time, thank you very, very much again, and a formal vote of thanks by Bharti or Manjula.
One point just before.
Yeah, please, sir.
I think the physical problems in the adolescents can be tackled and treated. The biggest problem, what I feel, is psychological and behavioral problems. Today in the young generation, what we are finding is that they are psychologically, they are so, what I can say is that impatient, and their behaviors have also changed. Just remember, Hema, when we were MBBS students, what was our behavior? Now I see as a dean, the behavior of the students in the college, I think it's very difficult to treat that part. I think Mehab can tell us something, what best can be done to see that the behavioral and psychological problems are solved. Can you say just one word, Mehab, madam?
I think the earlier the better. That would be the one word. So engaging early and often. Once they're entrenched in that teen brain, it's a difficult phase to explore.
Yeah.
So
we have a lot of work cut
be
out for us, as you can see from this deliberation. But once again, thank you very much, and it's very inspiring to learn some of the action points which we could implement in our part of the world. In fact, the college has a very strong, committed group of champions who would take our initiatives forward. So we are very hopeful that we will strike a role model, kind of a blueprint for many regions within our own country and beyond. Yeah. So now the formal note of thanks, because we can't leave May without once again expressing our heartfelt thanks, Bharti.
Yeah, thank you, Dr. May, for these wonderful deliberations and some sort of a guidance as how we could proceed in our country to see that our adolescents are physically and mentally on track, and better late. I mean, let's start early, as you said. Let's start early. And as Hema said, let us start and then find out whether we are on the right path. And then if we are wrong, let's correct ourselves, but we need to start soon. So thank you, Dr. Mabe, for being with us on this platform and sharing your views with us. And I would like to say that we would like to be in a conversation with you, taking your ideas and your tips to bring about a bright future for the adolescents of our country as well as global adolescents. Thank you very much. And then I thank Dr. Hema Divakar, the Dean of KCOG, who is has a huge list of very eminent speakers with very practical messages to our participants, to the gynecologists, that what we can do in simple steps. So thank you, Hema, for getting us this wonderful speaker on this very important topic. And our patron, chief patron, Dr. M.G. Hiramat, I have no words to express. Sir is everywhere. He has got, I would say, there's something in Tamil which we say, Sagala Kala Vallavan, that he is there everywhere. He seems to have a lot of hands and a lot of brains also. Sir, your points are taken and we need your guidance. I think from the Kasoga, we want to take up adolescent health on a major reward footing like situation, and let's start as early as possible. Thank you, sir, for being here with us. I thank Dr. Vidya Bhatt, the Secretary of the KCOG, for being with us. We have our executive members of the Kasoga, Dr. Manjula Patil, Dr. Shobha Bembalgi, Dr. Shobha Guri, Dr. Sri Lakshmi, and Dr. Lalitama with us over here. Thank you very much. I thank all the participants for participating in this very important webinar, and hope all of you have some messages to take home today and start tomorrow. Thank you very much for being with us today. I thank the SHIELD team, tech team from SHIELD, for being with us on this academic support team. And I would be failing in my duty if I do not thank Dr. Sheetal Doshi, Dr. Divakar, and the entire Divakar's team, who would I say the pillars for Dr. Hema Divakar, who is in turn the pillar of KCOG and Kasoga. Thank you very much. I thank the Kasoga tech team, Dr. Mr. Arun, and the office team. I thank all the participants and a very good evening to all of you. Have a happy weekend, and all of you. Thank you very much.
Thank you. Since May has not visited India, I will be gearing up to work my way towards bringing her in for our next Kasoga conference. And I do hope that we get a chance to meet her in person as well. Thank you.
Looking forward to connecting with us.
Namaste, good night.
Thank
Namaste.
you. Bye-bye.
Good night.
Thank you very much.
Thank you, ma'am. It was a nice webinar, informative.
See you.